Mhm. Oh. Hello, did someone just join us?
Hi, this is Erin.
Hi, Erin. How are you?
I'm good. How are you?
Awesome. I'm doing well. This is Marissa. And we have Katie from Michigan on, and Lindsay's on. We're going to wait for everybody else to log in.
Oh, great. Lindsay, are you there?
I'm here.
Hello, did someone just join us?
Hi, this is Kitty Parrington from Nashville.
Hi, Kitty. Marissa.
Hi.
Hello, did someone else just log in? Oh, bunch of people.
Yeah, this is Beth Krutzinger-Perry in Washington.
Hi, Beth.
Hi.
This is Marissa from Health HIV. I think I heard.
Hello,
Beth.
This is Lindsay from Nashville. Thank you so much for your patience.
Sure.
Yeah,
my other concern though is I can't. Am I supposed to be seeing something online?
Do you have the web address to connect to a webinar, or no?
Well,
I can forward that to you.
Okay. I have tried a couple of times, and I did register this morning, but I'm not getting a link to the actual webinar.
Okay, let me send. We'll get you the link for that.
Oh, I'm sorry. It's opening now. My link is now open.
Oh, okay. Oh, great.
Thank you.
Okay. Sorry, did somebody else join us?
Yeah, hi, this is Dawn Smith.
Hi, Dr. Smith. This is Marissa from Health HIV.
How are you?
I'm doing well, thank you. How are you? Thanks for joining us. We're excited for it.
Okay.
Did I miss somebody else while we were chatting? I know anybody from the participant states. We have Katie from Michigan. Is there somebody else on the line? Okay.
Are we just waiting on Maryland and Connecticut?
I think so. I think we have, yep, I think so. I think we just have Katie from Michigan, and then the NASHP staff are two presenters. And Dawn, you can see the slides, correct?
Yes.
Okay. We had
the first slide is up, right?
Yes, the first slide. So we're going to, my colleague Benjamin is going to advance slides for us because we were having some technology difficulties with the presenter login, the specific presenter login. So we wanted to make sure we had audio first and foremost. So we'll just have to, as you present, we'll just have to cue Benjamin by saying next slide. I think I heard a couple other beeps. Did we have some folks join us?
Steve Colangelo, State of Connecticut.
Okay, I heard Steve from Connecticut, and then there was somebody else?
This is Kip Kastner in Maryland.
Hi, Kip. How are you? This is Marissa Tonelli with Health HIV.
Hey, I'm able to hear, but no longer able to see. So I'm going to
Okay. I think a couple of people had trouble initially, and then the webinar showed up. Do you have a link to it, Kip? It's not loading.
When I both call in and go to this link, then I hear an echo. Okay, now so I can't put it both, because then I just hear everything twice.
Okay. Can you?
Kip, are you able to mute your speakers on your computer?
Yes. So we did that. That's good.
Perfect.
This is Connecticut.
Okay.
We're also on.
Oh, fabulous. I heard Steve. Who else is from Connecticut?
So this is Heidi Jenkins, and I have Mary Ann Buccelli and Dulce.
Oh.
Welcome, Connecticut.
Thank you.
Great. Is anybody from Maryland or Michigan missing other folks that were going to join us today?
This is Michigan. We have one person who's going to chime in a little late, but
Okay. Thanks, Katie. Awesome. So I think we have everybody on the line then, and we can start the webinar. So this is Marissa Tonelli. I'm with Health HIV. We're really excited to be collaborating with NASHP, the National Academy for State Health Policy, on a webinar series, or web meeting series, really. And so we're really excited to have, the three states that applied to be a part of this cohort: Michigan, Connecticut, and Maryland, and bring you guys some best practices from across the country and some subject matter experts to really talk through how to improve PrEP programming in your state or enhance the PrEP programming that already exists, and some of the ways to do that through overcoming some program and policy challenges in the delivery of these PrEP programs. So I think my colleague Ben is still on the line. So Ben, if you would advance to the next slide, that would be great. What I'm going to ask of everybody just logistically is that because we're on a conference line and everybody's lines are open, if you would mute your line unless you're presenting, that would be really helpful so we don't have background noise. Even just, wind coming through your window can be heard by everybody. We're also recording this, so if you do have colleagues that are interested in listening in and hearing some of the conversation later on, we'll make sure that that's available to you, and we'll share a link. The Q&A/chat box is to the left of your screen. Please use that at any time. I know the presenters would be okay if you're submitting it as they're presenting, but we do have specific kind of Q&A spaces for us to utilize throughout the presentation, and we'll cue people to open up their lines. We also have a webinar evaluation or a meeting evaluation that we will be distributing. It should theoretically pop up on your screen when you exit, but this is a little bit of a new platform, which is why we're having some issues. So if not, it's going to be on the link will be on the last slide, and we'll distribute it afterwards. Next slide, Ben. So as I mentioned, we will be recording. We'll also can share the PowerPoint after the presentation. So our objectives today are to discuss the national landscape of PrEP policy and programming, impart the importance of strategic planning and coordinated PrEP program implementation or expansion, discuss best practices in coordinated strategic planning between Medicaid and public health agencies, and discuss how to overcome common challenges to a coordinated PrEP program implementation or expansion. Next slide. Sorry, next slide. So we do have two really great speakers with us today. Then it went back. And Dr. Dawn Smith from CDC and Elizabeth from the state of Washington. Next slide, please. Okay, thank you. And we are going to kick off our our web meeting today with having both of these experts up here from Washington State and a subject matter expert from the CDC, Dr. Smith, give a little bit of background on PrEP program implementation and their experiences. And then we will be going through kind of the state-by-state presentations on where you are with your PrEP programming and where you would like to be and some of your challenges. So I'm going to kick it over to Lindsay with NASHP, so she can introduce herself first before we get into the state introductions, and then we'll have everybody from the state in this order introduce themselves to the group. So, Lindsay?
Sure. Thank you, Marissa. My name is Lindsay Sanborn. I'm a policy associate at the National Academy for State Health Policy, and NASHP is very excited to be working with Health HIV and your states to work on this project. So thank you very much. And my colleague, Erin Kim, who is a research analyst and is working on this project as well, is also joining us today. So perhaps we can start our state introductions. We'd love to hear first from the state of Connecticut. Could you just state your name and perhaps identify members of your team?
Hello, everyone. My name is Mary Ann Buccelli, and I work in the HIV prevention program. And I'm here with two of our colleagues, but we also have a colleague from our partners at DSS also on the call. But let's do Heidi and Dulce Dones Mendez.
Hi, I'm Heidi Jenkins. I'm the section chief overseeing HIV, STD, TB, and viral hepatitis.
I am Dulce Dones Mendez. I am the Expanded Testing Initiative Coordinator for the HIV Prevention Program, and I do some work with PrEP.
Great, thank you.
We got Steve, too, on the call.
Oh, beautiful.
Yeah. Steve Colangelo, I'm from the Medicaid side of the equation, Department of Social Services.
Welcome. We're happy to have you all here. Would Marilyn like to introduce themselves and their team?
Sure. Good afternoon. This is Kip Kastner, and I serve as chief in our Center for HIV-STI Integration and Capacity. Paul Foster is our PrEP coordinator. He's unable to be with us today. He's at a conference. And I don't know if Dr. Lisa Burgess is with us. She is the chief medical officer in our Medicaid program and will be participating.
Thank you, Kip. Michigan?
This is Katie McCumber. I'm the director of the Division of HIV-STD programs. We also have on our group Dr. David Knapp, who's the chief of the Medical Services Administration with Michigan Medicaid, but he's unable to be on the call today. And I think we have two other partners from Detroit. I'll let them introduce themselves.
Hi, this is Christine Human. I'm the medical director at the Detroit Public Health STD Clinic. We run a PrEP program at our clinic.
And I don't think Leanne's on yet. She was going to be a couple minutes late, but Leanne Savola, who's the AIDS director for the Detroit Health Department. She will be on momentarily.
Great. Thank you all. Ben, could you advance the slide, please? So we have a lot to cover today. As Marissa already pointed out, we're going to be covering the program and policy challenges for the delivery of PrEP. We're going to have a peer state presentation from Washington to talk about how they have implemented their PrEP program and overcome some of the barriers and identified opportunities. We will then hear from you, the Michigan, Connecticut, and Maryland, to talk more about what your states are doing and have time for questions and answers throughout. And then we'll wrap up with a brief overview of some of the webinars that you have to come. We have a lot of ground to cover, so please excuse me if I keep the facilitation moving today. Next slide, Ben. So I just want to take a moment to introduce our first speaker, Dr. Dawn Smith, who is the Biomedical Interventions Implementation Activity Lead in the Epidemiology Branch, Divisions of HIV/AIDS Prevention, Centers for Disease Control and Prevention, who will be giving us a rousing presentation looking at policy and program challenges for the delivery of PrEP. Dr. Smith, take it away.
Hello. I don't know how rousing I'll be, but I'll try to be informative. So next slide, since you are going to get copies of these slides, I'm going to go through some of the data-heavy slides a little quickly so that we can get to the state presentations. But first of all, PrEP is used the term PrEP is used to mean a lot of things in the HIV literature, and I wanted to clarify that for my presentation, we're talking about daily oral prophylaxis with tenofovir and FTC, otherwise known as Truvada, for adults at substantial risk of acquiring HIV infections. So that includes MSM, heterosexually active men and women, persons who inject drugs, any of whom have behavioral indications of ongoing sustained risk of HIV exposure. This oral PrEP requires clinical screening, prescription, and safety monitoring at quarterly visits. I'm not going to be talking about agents that are currently in trials and not yet FDA approved or available for use in the U.S., and these are sometimes also called PrEP. But topical antiretrovirals, also known as microbicides, vaginal rings, injectable prophylaxis, are not things that we are ready to think about policy for because they're not yet available. Next slide. So at CDC, thinking about PrEP for the national population, we were pleased to see that the National HIV/AIDS Strategy for 2020 specifically included scale-up of PrEP for most at-risk populations. In addition, the HHS Office of HIV Programs has helped the federal agencies that are involved in healthcare delivery to coordinate and to some extent collaborate on the scale-up of PrEP. So that would include HRSA, both the HIV/AIDS Bureau and the Bureau of Primary Health Care, CDC, AHRQ, the VA, the Department of Defense, Indian Health Service, a variety of federal agencies that are involved in healthcare. At CDC, we focused initially on the development of clinical practice guidelines, and we published those in a provider supplement in 2014. We have an update that's currently in final review and should be out within the next month or two. We've worked on adding PrEP activities to health department and CBO program awards and providing PrEP materials and capacity building assistance for health departments, for clinicians, for patients, as well as for CBOs. We are also leading demonstration projects with both health departments and community health centers and conducting implementation research and evaluation studies of PrEP, the need for PrEP, awareness of PrEP utilization, and its potential impact. Next slide. The first step we took was to develop a national implementation logic model. This is the most recent version of it. What you see in blue are the areas where CDC has current activities ongoing. And once we had developed the logic model, we were then able to go back and figure out where were the areas where CDC could play a key role in assisting PrEP stakeholders to scale up and roll out PrEP effectively in order to reduce HIV incidence. Next slide. When we think about strategic planning and coordinating program implementation or expansion, there are a couple of unique things about PrEP as compared to, for example, HIV testing or treatment rollout. On the left is a diagram from one of our demonstration projects in which we identified community-based organizations, healthcare providers, and behavioral health and social service providers as part of a collaborative with the health departments in order to provide the services necessary to scale up PrEP and make its use the most effective in the populations. One of the things that's different about PrEP is that many of the cascades that are past slide. Many of the cascades related to PrEP focus on the patient side of the equation. So identifying people at risk, seeing if they're interested in PrEP, linking them to a PrEP program, getting them started and retained on PrEP, and achieve significant adherence over the long term to provide protection. However, the other issue that's been very important is developing the provider side of the cascade, because when PrEP was first approved, there were not very many providers who knew about it, were aware of it, and most of them were not providing care to HIV-negative persons. So while we're preparing patients for PrEP, we also need to be preparing providers. So especially those that are caring for high-risk HIV-negative patients already, to be sure that they're educated about PrEP, willing to provide it, and have the training and resource tools necessary so that when we have identified patients, we have places to link them. Next slide. One of the things that has become apparent in the last year or so is that it's very important to consider the heterogeneity of HIV risk across the country. While we focus on a national level, we're also acutely aware that the needs for PrEP are very different in different parts of the country. These are slides from AIDSview showing the number of newly diagnosed persons in 2015 by transmission risk group. And what you can see is that MSM in particular are pretty widely distributed in terms of their need for PrEP to prevent new diagnosis of HIV infection. On the other hand, heterosexuals and persons who inject drugs are not widely distributed. And there are specific places where PrEP programs for these individuals may be more important to be located. Next slide. The other disparity that is of concern to us is the racial and ethnic disparity in the distribution of new infections. So if you compare the two maps on the left, you could see that for white MSM, the number of persons is really pretty much scattered throughout the country. On the other hand, for black MSM, the number of persons is roughly is highest in roughly half of the states. If you look on the right side, comparing black women and white women, again, you can see that the overall rates are lower for white women than for white MSM, with a limited distribution by state. But for black women, there is much more. There are many more states that have significant numbers of black women newly diagnosed with HIV infection, and the states overlap significantly with the places where black MSM are found. Next slide. So having some sense of where the prevention need is, we then want to look at how the current uptake of PrEP is occurring. So this is the most recent slide from Gilead Sciences, and these are individuals starting PrEP in a given quarter. And what you can see is that in the 2 years between the interim guidance that CDC issued and the final guidance in 2014, there was a small but steady number of persons starting PrEP. Once the CDC issued its clinical practice guidelines, there was a marked increase, and that was sustained through most of 2015 and now appears to have stabilized. These are people who are starting PrEP in each quarter, but by the first quarter of 2017, there were an estimated 120,000 persons taking PrEP, Truvada for PrEP. And by the second quarter, made it 136,000 persons. So that's a sort of minimum estimate of the prevalence of PrEP use in the U.S. Next slide. However, when we look at new starts by race, ethnicity, sex, and gender, what we can see is that most of the patients who are starting PrEP and the fastest increases are occurring in white persons. Hispanic and African American persons are next, and Asians have the least number of starts. What's also striking is that among white persons, there are a significant number of women that haven't been increasing significantly over time, whereas the number of Black and Hispanic women are fairly small and also haven't been increasing over time. This is not the pattern that we have seen in new HIV diagnoses. Next slide. In fact, this slide compares the population distribution by race ethnicity. On the left, the estimated number of new HIV infections on the right, and the PrEP use through September 2016 in the center. And what you can see comparing the center to the right is that while 26% of new infections occurred in white persons, 73% of PrEP prescriptions occurred in white persons. While 44% of new infections occurred in Black persons, only 10% of PrEP use was in Black persons, and a similar pattern is found for Hispanics. Next slide. So, having a little bit of understanding of the epidemiology of new diagnoses that we want to prevent and Truvada use for PrEP, we want to talk a little bit about best practices and coordinated strategic planning, particularly around financing PrEP care. Next slide. No, next slide. Oh. You're going backwards instead of forwards.
Ben, I think this slide is at the beginning, so you have to advance forward, if you don't mind.
We should be on slide 12.
Ben, if you're there, could you just chime in on the audio and let us know if it's freezing or something so that we know if we should move to a Q&A break? Okay, so while there might be something going on the producer end, does anyone have any questions that they wanted to chime in? Oh,
I'm sorry.
Hi, Ben.
I'm going to conference back into the main line. I apologize for the delay.
Okay. So does anyone have any questions, anyone else on the line of the states at this point for Dr. Smith while we're regaining control of the slides? I think I also heard a couple of other beeps, so I know if anyone else joined while we were Dr. Smith was mid-presentation, you'd like to announce yourself.
790. You will now be placed into conference.
Oh. Hello?
Hello?
Hi. Ben, are you on? Okay. I'm not sure what just happened there. Sorry. So this is, oh, okay. So can you advance, are you able to advance the slides, Ben?
I am, yes. Are we trying to
We're supposed to be on slide 12.
Slide 12, okay. All right. I must have different numbers than you.
Okay, could you just, we'll tell you when to stop, so just start advancing.
Okay.
The next slide is covering the cost of PrEP care.
Covering the cost of PrEP care. Oh my gosh.
It should be the one directly after this slide.
There we go. Okay, yeah, so there were 6 in a row that were the same. I apologize. I have less view than I would like.
Okay. All right. So in terms of working around covering the cost of PrEP care, this was an initial concern by both consumers and providers because the medication itself is fairly expensive. However, as with other medications, most people don't pay the market price for a medication that they receive in a healthcare setting. What was determined was that it was important to include, to understand both insurance, commercial and employer-based insurance coverage, what to do with persons who are currently uninsured, and particularly those that are potentially eligible for Medicaid and ACA plans, and the few who are ineligible for both ACA or Medicaid. Fortunately, almost all insurance programs cover PrEP for HIV prevention, including most Medicaid programs. And in those patients, the medications, the lab tests, and the clinic visits are all billable to insurance. So getting uninsured persons signed up for ACA plans or for Medicaid if they're eligible in expansion states has been a very important component. For people who have absolutely no insurance or who are underinsured for some reason, for those who have an income less than 500% of the federal poverty level, the drug company Gilead will provide the medication free. Lab tests and clinic visits can be gotten inexpensively by using safety net clinics like FQHCs. In addition, certain states have developed PrEP-specific assistance plans, some of which cover medication but not clinical care costs, some of which cover clinical care costs but not medications. So it's important to know this is a place where states have played a very important role, both in coordinating with the Medicaid program to be sure that the Medicaid program understands why PrEP should be covered, but also in terms of whether there is a need to develop a local PrEP assistance plan. Next slide. So CDC took a step back and said, of the 1.2 million adults that we estimate have indications for PrEP use, how many need financial assistance? And overall, our analysis showed that less than 1% need financial assistance for both the medication and the clinical care, and an additional 7% need assistance only for the clinical care because they're eligible for the medication assistance from Gilead. This pattern holds across all transmission risk groups, but there are differences in which proportions are eligible for which services. And again, this is a slide I don't want to go through in great detail, but I'm glad that you'll get the copy and the paper is cited there. Next slide. The other thing that we've been looking at there has been a was not seen in, for example, African American persons, the blue line, African American MSM. There's data not shown here to suggest that uptake of PrEP has been almost exclusively among white San Franciscans, and so there's a cause for concern as well as the cause for joy in this slide. Next slide. Okay. So one of the issues is this due to the increasing use of early antiretroviral treatment? And so they also provide this very nice graph showing that since 2012, while there's been no change in the proportion of persons living with HIV who are virally suppressed, as you see, there is an associate that when they started doing early ART, so at diagnosis, people are immediately put on ART regardless of CD4 count. There was a small decline between 2010 and 2013 that could be attributed to universal access to ART. However, 2013 is when they began to aggressively roll out PrEP in San Francisco, and you can see that the decline accelerated after that, suggesting that PrEP is an important component in addition to early ART at a population level to reduce new HIV diagnoses. Next slide. So how to overcome common challenges? Basically, CDC has been working at coordinating HIV and STD activities and insurance and Medicaid policy and data. At CDC level, we did that by early consultation with CMS about whether the national CMS would support the use of their funds for PrEP, and we were told yes, and the central office sent letters to all the state Medicaid programs indicating their support. Although it is not part of the essential benefits that are paid for federally, it still has to be something that the state prioritizes its portion of the Medicaid funds for. We've been working about how to increase the number of PrEP-trained clinical staff. And that's especially been primary care providers have been a special focus for us, as well as STD care providers, because they are most likely to see high-risk uninfected persons. Meanwhile, from other data, we know that most PrEP providers are actually infectious disease persons, largely because of their familiarity with antiretrovirals. We've been working on PrEP awareness campaigns targeted to key populations. We also think that there's a role for the increasing involvement of certified financial navigation staff to help people negotiate the various financial assistance programs. We've been supporting PrEP training for DIS officers who see contacts of persons with HIV and STD diagnoses who may be appropriate for PrEP. We've been working with a number of pharmacy groups on collaborations, sometimes to actually provide PrEP in pharmacies where they have clinical staff within a pharmacy, but also in terms of supporting adherence for patients and HIV testing for patients where the pharmacy is prepared to do that. We've been exploring the role of certified community health workers to do PrEP navigation and support. This would be an important development because the work of these kinds of workers is billable to insurance. And then we've been working with STD clinics to increase their capacity to bill persons with insurance. Also to make their PrEP services more sustainable. And then collaborations with CBOs about educating clients about PrEP and linking them to sites for PrEP care. Next slide. One of the most frequent questions we got asked early on was, given that people who are virally suppressed are very unlikely to transmit HIV infection, shouldn't we just focus on treatment as prevention? Why do we need PrEP? However, if you look at the cascade in a different way, so for example, of those who are on ART but not virally suppressed, there are about 30% of persons living with HIV who are of all those persons who, yes, there are about 30% who are not virally suppressed. Their partners are appropriate for PrEP. They would not be protected from transmission. Similarly, for persons in care but not on ART, that's 36%, et cetera. And specifically for those who have undiagnosed HIV infection, which is about 13% of the population. So we want to expand both early and continued treatment for those diagnosed with HIV infection and PrEP for those with ongoing risk of exposure. Next slide. Okay, the other thing that we're very interested in working with health departments on, we've been monitoring PrEP use at a national level, but we believe it's really important to monitor PrEP at a jurisdictional level, both state and local health departments. And that can be done in a number of ways. To monitor PrEP use and provider practices, there's a role for healthcare databases, which are basically based on billing and by diagnosis codes and procedure codes linked to medical record data. You can look at these issues. New York has done this with Medicaid data. It can also be done with Medicare data. Some states have what are called all-payer databases, which can be used to do this. And then, similar to what CDC has done, states can purchase databases from pharmacy data or from commercial insurance data to supplement their ability to look at this in their state. We also need to look, though, however, at PrEP adherence. The effectiveness of PrEP is really dependent on sustained adherence. And so adherence, retention, and care and the number of seroconversions among PrEP users can't be looked at in healthcare databases effectively. But they can be looked at in sentinel surveillance clinics. This is an activity that New York City, for example, has pursued for several key chronic illnesses, and they're now using it for PrEP. We need to have a better understanding of whether providers or key population members are aware of PrEP, whether providers know how to provide PrEP, and whether potential users know where to look for PrEP, whether to seek care for PrEP. This can be done with local surveys of critical populations, for example, local NHVS surveys, but it can also be done with local surveys of clinicians using on the web or using state medical directories. In terms of seroconversions, we have worked with our HIV colleague, our surveillance colleagues, to change the way antiretroviral use on new HIV diagnosis case reports is recorded so that we can now tell whether persons were receiving PrEP or post-exposure prophylaxis at the time they seroconverted. And then what you'd like to do, some of these things will give you numerators. You would need local denominators to then look at coverage among those with indicators. What we have published so far is national denominators, but I'm pleased to let you know that we will, in the next couple of months, be publishing a paper that has estimates at the state level, persons with indications for PrEP by transmission risk group and race ethnicity. And at the same time, we will put online a web-based calculator so that jurisdictions can use the data that we used to explore what it might mean for a particular MSA or county. Next slide.
I'm so sorry to interrupt you, but I think due to the technical issues that we had earlier, we're going to have to move along a little bit. Is there any slides that you feel would be most relevant to the discussion today? Again, I apologize.
Okay, there's just 3 more slides, so I think we're pretty good. I'll go through the next 2 real quick. So we also noticed that there was a need to provide a way to find PrEP providers. And so we worked with Emory to provide an online PrEP provider locator. You'll see that there's a little button there that says Add a Provider. This is something that health departments or individuals can do. Next slide. And so I pulled up the PrEP locator information for the 3 key states here. And I think I'll just point to Michigan, for example. According to the PrEP locator, there are no providers in Detroit. And we know that that's not the case. So one of the things health departments can do is help to populate this application or provide their own application so that providers can make their availability of PrEP known to potential users. Last slide. So there are a few policy issues that you should expect to have come ahead in the next year or so. Number 1 is that we need to work on better access for PrEP for Black women and Black MSM since they're currently being massively underserved. The second thing is that we are following closely what the impact of changes to the ACA will mean for coverage availability for PrEP care. PrEP has been accepted for USPSTF review, and we are expecting the results of that review in early 2018. That obviously may have some implications for cost and coverage of PrEP. The FDA is about to review adolescent safety data for PrEP. Currently, PrEP is only recommended for adults, and they may have a decision again in 2018, which would impact policies, particularly at the state level, having to do with consent, confidentiality, and other issues that are specific to adolescent use of medication-based treatments. There is a potential availability of generic TDF-FTC, which would help lower the cost. And there is a new form of PrEP that is currently in clinical trials with something called TAF instead of TDF. And if those trials show effectiveness, again, that would have both impacts on the effectiveness of PrEP, but also on its cost. And unfortunately, as with the TDF-FTC trials, we will have results for MSM before we have results for women, complicating the inclusion of appropriate numbers of women in PrEP care. So last slide, that's the end of my presentation. And do we have time for questions, or should we go directly to the state presentation?
Thank you, Dawn. I think we're going to move on to Washington's presentations, and thank you so much. And I know that the states have lots of questions because the data you presented was fantastic. So I would just ask states that if you have specific questions for Dawn, to enter them into the chat box, and we can come back to those later or follow up with Dawn after the webinar with any specific questions. So next slide, please, Ben. Next slide, please. I would love to take this opportunity to introduce Beth Krutzinger-Perry. She is the Deputy Director of the Office of Infectious Disease at the Washington State Department of Health. and she's going to give us particular insight to PrEP in Washington State. Beth, thank you so very much for joining us today, and I'm looking forward to your presentation.
Hi, everybody. Thank you so much. Before I start, I know we have a bit of a time issue, so I just wanted, because I can condense, I know we would originally looked at 20 minutes, but shall I try to keep this to 15 so I can kind of speed through it a couple of places?
That would be great, and if we have extra time at the end, I will be happy to give it back to you.
Absolutely. Okay, so if we can, basically I'm going to kind of go over the overview of how things have rolled out in Washington State, talk about our partnerships, a little bit on data and outcomes, but that's pretty light, and then some lessons learned. So if we can go to the next slide. So I can't really talk, and I tried, I can't really talk about PrEP in Washington State without giving you the context of EndAIDS Washington. These things happened very close together, and honestly, the successes that we've had with our PrEP partnerships in large impact have been related to the fact that our governor created the EndAIDS Washington Initiative on World AIDS Day of 2014. And once that was rolled out by the governor and had the governor's support, a lot of doors opened for us to align our efforts and our partnerships. I've listed some of those here with some underlined groups that are kind of specific: healthcare providers and healthcare systems, our healthcare authority, which is the entity, the state agency in Washington State that oversees our Medicaid in addition to other services, the office of our insurance commissioner, individual insurance plans that function inside Washington State, as well as managed care organizations, and certainly our local health jurisdictions. I listed some others, but I have to be able to talk about and be honest with you that because we had a governor sign off on this initiative, and PrEP was a huge part and remains a huge part of our EndAIDS Washington campaign and effort, that has aligned a lot of our partnerships in a way that I don't know would have happened without that. Next slide. To go back, this is really just a very kind of a dense slide about our HIV community planning, and the only part of this I'm going to pull out is that we did some priority outcomes with our HIV community planning, which was focused on the Department of Health. Highlighted there, you see an increased use of PrEP. This framework rolled out in 2013, and we set up a goal, which later became the goal that was attached, or a similar goal attached to our EndAIDS Washington effort. We also trained and required PrEP referrals from our disease investigators statewide for gay and bi men, in particular diagnosed with syphilis and gonorrhea. And then we funded a community mobilization effort and a media campaign in our largest urban area, obviously in Washington, that is Seattle. Next slide. So after the rollout of the framework and after before the governor signed on to the EndAIDS Washington effort, our programs here convened a meeting with about 50 prescribers in Seattle, 50 PrEP prescribers in Seattle, to kind of do a bit of a focus group and understand what they were hearing from patients, what the barriers were. We have focused a significant portion of our effort in Washington State on our providers, clinical providers. So we convened that meeting. We have done a lot of prescriber recruitment and training, outreaching to providers statewide. We have about 490 providers from about 260 facilities listed in our PrEP DAP program, which I'll talk a little bit more about. Dr. Smith showed you the prescriber map that has been created. We actually created a local one for Washington State that we can go into a little more detail for, although we use both and we publish both on our website. We funded Project ECHO through the University of Washington to do PrEP clinical provider technical assistance, which I think has been helpful to particular providers who have the time and capacity to devote to that kind of an effort. We've created these provider cards, which you see just kind of displayed there, which are really small laminated cards which we've given to providers, which on the front basically talk about the basics, the side effects, what screening and testing needs to be done, and then on the back aligns with what our state guidelines are in Washington State for who should be prescribed and recommended on PrEP. We've done professional conferencing, tabling. We do a constant review of insurance denials that may come through our program, and formulary reviews as well for insurance plans in Washington State. Next slide. So in this chronological context, and to improve the access to PrEP, in 2014 we established our PrEP-DAP program. This was a collaborative effort between HIV care and prevention programs here at the Department of Health, and it was built on the backbone of the state AIDS drug assistance program. We had a $2 million budget that was a general fund state for us, and originally we projected to serve about 200 customers with that money. It was really a guess of how that was going to go, since we knew very little about what the cost was going to be. Our program was set up on an eligibility based on risk rather than income. It remains that way today. And I've stated again that it was funded exclusively with general fund states. This program, and we can go to the next slide, was really only to cover the medications at the time in 2014, not the wraparound medical services. We are expanding our PrEP-DAP program by January of 2018 to include medical out-of-pocket and laboratory costs for our enrollees as well. So we have the providers, we have the PrEP-DAP program, and then we have our partnerships. I think we missed one. I'm sorry. Can you go back one slide? Okay. Community partners, our CBO partners. In 2016, I'm sorry, forward one more. Back one more. There. Okay. In 2016, we funded 9 agencies statewide through our HIV Community Services Program for people at high risk for HIV, and to begin building their capacity to do PrEP navigation for persons at high risk. This is really a paradigm change for our prevention program, setting it up as a long-term engagement from prevention, as opposed to what, in my words, has been more of a catch-and-release program in the past. We've created PrEP tools for our navigators that include an assessment and intake screening, and we're in the process of developing a data system to track PrEP referrals, utilization, and retention. This is very new. These contracts began in 2017, so we are only finishing the first year of this. We hope that 2018 will give us an opportunity to continue to grow and learn more about how to do that, but that has been a part of our community-based effort. Next slide. Partnerships. So I mentioned earlier we had PrEP guidelines. We did co-author guidelines with our partners at the Public Health Seattle King County Public Health Department to develop Washington State specific PrEP provider guidelines, which were published and distributed to all clinical providers across the state. We maintain those on our website and review those with King County on a fairly regular basis. We also, as I mentioned before, DIS, or disease investigation staff, needed to develop the capacity to develop their own PrEP provider networks locally and to make those referrals, so that has happened. We've also, and I think this was mentioned, we are an expansion state for Medicaid, so PrEP in our Medicaid program has always been covered and remains covered, including all of the comprehensive services that go with that. And we do make regular referrals for individuals who apply to the PrEP-DAP program when we know they're Medicaid eligible, so that they can access care through the Medicaid program for comprehensive health care, not just PrEP. We don't currently have a data share agreement with Healthcare Authority for our PrEP data. We began that conversation a couple of years ago. But, as I'm sure many of you know, Medicaids are quite busy, and we joined the HIV Affinity Group, and really that data share agreement for HIV positive and Medicaid became the priority. So PrEP and other infectious disease issues have been on the back burner. They have been successful in the data share for our HIV positive population and are currently working collaboratively with our Medicaid program on that data. So I'm hoping that success will give us an opportunity to revisit this, but currently we do not have access to that data. The other thing I'll talk about is that as a part of this partnership with our Medicaid program, we submitted, and the title here is Improving Healthcare and Health Equity for LGBTQ Persons. We submitted a proposal to the PrEP Collaborative, co-sponsored by the Healthcare Authority and the Department of Health. Briefly, the PrEP Collaborative in Washington is kind of a local version of the United States Preventive Services Task Force at the federal level. The PrEP Collaborative is legislatively designated in Washington State. It was established in 2011 and represents membership across our state of healthcare providers, health insurance plans, managed care organizations, and content experts. They accept 3 to 4 proposals a year to do quality improvement projects in the healthcare system. They convene for a year in small work groups working on a particular topic, and then when the proposal is finished, they make recommendations of how to implement this. At that point, the recommendations are sent to the Healthcare Authority, our Medicaid program, for review and approval, and then implemented by all Medicaid providers. Getting an opportunity to submit this proposal, which has been accepted by our PrEP Collaborative, puts us in a partnership opportunity with our Medicaid program and all healthcare players across our state to actually, PrEP is certainly a part of our health equity program in this proposal, but it's going to give us a chance to implement provider care at the individual level in a way that we would never have had a chance to do on our own. Let's go to the next slide. So we're very excited to see what will come from that proposal. I've listed a couple of the things here that were in the proposal that has been accepted: age-appropriate screening, inventory of health equity practices and competencies, protocols, policies, and practices to improve medical care for LGBTQ patients, the implementation of our Men Who Have Sex with Men STD screening and PrEP implementation guidelines, and then recommendations of indicators and outcomes. So in 2018, our PrEP Collaborative will be working in partnership with their work group and DOH and the Medicaid to develop these recommendations, which will include PrEP, and once finalized, then be implemented across our state. So we're very excited about that. We would not have been able to do this without my medical director here at the Department of Health signing on and bringing her colleague, the medical director of our Medicaid program, to sign on. And actually, the medical director of our Medicaid program is chairing that work group and championing this effort for the Department of Health through the PrEP Collaborative, and we're very excited about that partnership. Next slide. I put in a slide on communication streams. I've already mentioned that the NDAIDS Washington opened many doors, and I've listed these here. Our Medicaid program, Office of the Insurance Commissioner, who regularly allows us to come in and talk to them about health plans and concerns that we're seeing in the health insurance world in Washington State. We have direct contact with health insurance plans as well as provider associations and certainly our local health jurisdictions. The Secretary of Health in Washington State also has the NDAIDS Washington effort as one of his 4 priorities. That gives us a shared message. There are very clear deliverables in our NDAIDS Washington effort that are tied to PrEP. It focuses our effort, and it gives leadership become our allies in the programmatic work, which honestly has transformed the effort that we can accomplish in Washington State. Next slide. I'm going to go really quickly through this. These were just some brief outcomes of our PrEP DAP program. These are the basic demographics. 96% male, primarily a homosexual, gay, MSM population in our PrEP DAP program. You can see here clearly we are repeating what Dr. Smith has already said, only 3% black. That is drastically underutilized for our African American population. Our risk factors of the folks who are in the PrEP DAP program are listed here. Let's go to the next slide. We've looked at some discontinuation, PrEP use and discontinuation, so I've just briefly reported this. Is what we've learned in our survey of our PrEP DAP participants. It has been, primarily they seem to be on the intervention for 19 months for the folks currently using, 12 months for those who are no longer using when we took the survey. They had a fairly high self-reflected adherence. 92% took it every day. 65% reporting missed doses in 30 days, and 31% never missed a dose. This is obviously client self-report. Next slide. Sexual behavior change, the majority reported no change. Of those reporting a change, we did see an increase in those identifying that they increased their receptive anal sex or anal sex and the number of their HIV-positive sex partners, as well as an increase in the number of sex partners overall, with also a self-report of decrease in condom use. Next slide. Because the program in the Office of Infectious Disease, we are an integrated program between HIV care, prevention, and surveillance. We do take our PrEP data and run it through our STD data on I think about a biannual process every 6 months. So we asked some questions on the survey about STIs, and what was discovered is that before PrEP, 56% tested every 3 to 6 months. While on PrEP, that increased to 98%, which is very good. We are happy to see that. It shows that they're being adherent to the guidelines and that providers are following those guidelines. In a match with our surveillance data, however, we did see a higher rate of diagnosis observed after our clients enrolled in the PrEP DAP for 1 year compared to their enrollment, their STI rates prior. This could be because of the testing. There's really no way for us to know. This is we're trying to monitor this on an ongoing basis, as I know many programs across the country are doing. And in another match of frequent testing of 3 to 6 months was highest among those who did have an STI diagnosis. Next slide. This is just a quick visual of our utilization on our PrEP DAP program. The red bars are those individuals who are actively enrolled in the program. The blue bars are those who are filling the medication. We only know if they fill the medication if we pay for it. So if we don't pay for it, but they still pick it up because they've met their out-of-pocket, they've met their deductible, they paid the copay themselves, there's no way for us to know that. So this is the same for us in PrEP DAP as it is in our ADAP program. But I wanted to show you the bars because you can see that we tipped out our enrollment over 700 people in February of 2016, and at that point we were going to be over budget. So we began bringing the program down, referring individuals to the patient assistance programs as much as possible so that we have reduced the number of individuals on the program who we're paying full cost for, and in many instances now we're more of a safety net program. Next slide. Lessons learned. There are so many. The first lesson is PrEP is effective. We have had 0 seroconversions for those active on the PrEP DAP program. I would encourage you to let your community be your advocates on this to your state leadership. That is what got our programs moving in Washington State. The community bubbled these up and to the governor, and were able to accomplish movement that we would probably not have been able to do. Partnerships are necessary to achieve success for PrEP in high-risk populations. You cannot do this from a public health perspective alone. We have to have our partners. We need agency leadership as strong allies. And health departments, both local and state level health departments, should use PrEP to partner and communicate with communities, providers. It isn't easy in many instances. It's a fairly simple clinical practice to get people up to speed on. It's not nearly as complicated as Hep C or HIV. So we have found that once people get the basics, they feel pretty energized about being a PrEP prescriber and moving people through that process. And I would encourage you to rally behind an aligned and a clear message if you can possibly come up with one that is simple and can be shared across all agency groups. Next slide. An integrated approach between prevention, assessment, care, and treatment is absolutely necessary. We would not have been able to accomplish most of these issues if we weren't all working together, so that's been a real benefit for us in Washington. I need the expertise of the ADAP program, and I need the collaboration and the expertise of assessment to track our seroconversions and STIs. I will say that new HIV cases in Washington State remain constant. We have not reached a saturation level yet of our high-risk populations to show a decrease in our new infections. Our viral suppression for persons living with HIV is 73% state completely and 79% for those who know their status. So we have a fairly high continua, but more needs to be done. And I would encourage you to do something new. It doesn't have to be perfect to start out. Give it a try. You can always autocorrect later. And we in Washington State continue to learn from those of you on the phone and our peers across the country. Thank you.
Elizabeth, thank you so very much. Those were excellent takeaways, and I love hearing about what Washington is doing. I think what we're going to do is, as states, if you have any questions specific for Elizabeth, please enter them in the chat box, and we will come back to them at the end after we hear everyone's presentations, just to make sure that we have time to hear from you as well. Next slide. So I would like to start our state round robin. This is the portion of the presentation where we get to hear from you, and we're really excited and hope that the other states on the call will find this really interesting and useful, and this will really spark conversation amongst the states and with our state presenter and with Dr. Smith on ways that you can leverage resources and tools to improve your PrEP programs. So I would love to hear from Marianne Buccelli with Connecticut.
Hi there. Hello, everyone, and thank you for having the Connecticut team on board here. I just want to say Washington rocked. That was quite the presentation, and I hope we get copies of that presentation because we will definitely be using that as we face to our next level of PrEP implementation in Connecticut. So next slide. Or do I do this? Okay. Okay. So because we tried to keep it aligned with your outline, I didn't put a lot of stuff, but I will preface that Connecticut is a small state, but we were trying to be very proactive as we could. So in 2014, we actually tried to integrate more PrEP activities into our planning processes for HIV prevention and care as well. So we did a few summits, which was really like a way to get and engage providers to come together from across the state and talk about what PrEP was. It was really about heightening awareness. It was about getting early adopters to the table. We had a few medical providers who were doing PrEP, and we wanted to learn about what they were doing with their pilot projects. So as a result of that, it spawned a few other PrEP summits, which we just kept growing and more people became involved. Finally, in 2016, we launched a PrEP pilot program, and which resulted in this PrEP navigation intervention that we now are able to fund. So across Connecticut, we have about 8 navigators. These are truly community folks. They are situated in CBOs as well as in community health care, the FQHCs in Connecticut. As I said, there are 8 funded and non-funded sites. And I'm really glad that the doctor earlier showed our map because all of our sites are literally situated in those areas where we have a higher incidence, and it's along what we call the 91-95 corridor, which is our highway system. So it's accessible and people travel. Basically, in Connecticut, you can get anywhere in the state within 2 hours. So just to give you some perspective of how tiny our state is. The number of people that are in PrEP, as our last data report showed, was 444. It is limited to what gets inputted in data entry into Evaluation Web, and I'll talk a little bit about how that is also a barrier for us because we are not able to collect data from all of the providers that are not funded or private doctors who are doing PrEP. PrEP services by county. There are 4 major counties in Connecticut. Fairfield has 214 clients, New Haven 139, Middlesex 55 clients, and Hartford 36 clients. There are actually a lot more. These are the major counties that have most of the incidence of HIV. Next slide. So what we were wanting to show with this slide is, to the right is our recent newly diagnosed cases in Connecticut by county from 2011 to 2015. And as you can see, Hartford region is probably the largest number at this point, followed by New Haven and Fairfield County. The map to the left is persons living with HIV in Connecticut by county, and the number of people receiving PrEP services by county in 2016. So as you can see, the red dots are where our main centers for PrEP services are located in the county. And I know it's hard to see, but you could see, the number of the people that are on PrEP by that county. Next slide. So one of the things we tried to do, because we didn't have a lot of money, and one of the things, the benefit of being from Connecticut is that you're between Boston, Massachusetts, and New York, which have a little more money than we do and are really proactive, and they are helpful when we ask other jurisdictions to help us with things that they may have already developed. So I wanted to say that because New York City launched a great PrEP campaign very early on, and we decided not to reinvent the wheel, and we had no resources, literally. And we said, can we use your messaging, some of your posters, some of your informational packets, and they allowed us to do that. We were able to replicate them here, tailor them a little bit for Connecticut audience. We also had the support from our commissioner, who at that time was newly appointed in Connecticut, Dr. Raul Pino, who is just a wonderful supporter of all the HIV work that we do, specifically around PrEP as well. So we had a welcome letter for him to providers. He was able to provide that for us when we did a mass mailing to all the medical clinics in the state about what PrEP was and trying to get providers to learn what it was and how they can refer to the local clinic that was providing services. So it generated this nice little sheet that you see here. We have this uploaded. It gets updated regularly on our webpage. We also have it updated on multiple sites of the programs that we fund. We have also a website called Positive Prevention CT, which is everything prevention in Connecticut. And we also have this listing, and it gets updated regularly as new providers come on board. So that's,
Marianne, I'm very sorry, but could I give you a 2-minute warning?
Sure, I'm almost done. Keep going to the next slide.
I apologize.
No problem. So these slides are really just pictures. So this is kind of what we used. This was New York's model, so I always give a shout out to New York. We had them on the buses and on billboards. Next slide. These are the outreach cards. We did the navigation services. We did a training through our CBA provider through the CDC, and we had them come out and do a training for all of our community-based organizations in which we passed out this literature and information to do outreach with. Next slide. So we have 3 main goals. Let me just put this out first. Connecticut still needs to improve the data sharing agreement process with our partners at DSS, and I'm really glad that Steve is on board. Steve Colangelo, got to give him a shout out because he wants to continue to work with us so that we can at least come up with a way to share the data needed to find out who is on PrEP and where do we have to target outreach efforts. We also want to be able to address the concerns. That's the first bullet, having to do with safety, cost estimation of risk compensation, and all those other things that have come out through the work our PrEP consultant did when he was with us. And then we also, our hope is to have a Connecticut Health Exchange cover the medications approved by FDA for PrEP. Next slide. You can go ahead. Okay, so these are kind of the 4 challenges. Again, circling around the data collection point, we're hoping CDC will help with a streamlined effort to collect this information through all their CDC programs, so we're hoping to get guidance on that. There's also a lack of PrEP utilization data in Connecticut. Not everybody is eager to share their data on a timely basis so we could tell the story about who's on PrEP in Connecticut. Obviously, as what we heard today, PrEP affordability continues to be an issue, especially in Connecticut. We are an expanded Medicaid state, but it's still very expensive because it's on a certain tier, and many folks can't afford that, and so they will most likely not be on it for a long term. And also the community knowledge with PrEP in general and uptake. Next slide. That was it.
Thank you so much, Marianne, and I apologize for making you rush, but I'm going to turn it over to Kip Kastner from Maryland. And Ben, if you could advance the slides, that would be great. Thank you. Kip, it's all yours. We have 5 minutes.
Good afternoon. Okay. So we've been focusing on building provider awareness. We didn't want to have a lot of consumer demand before we had some supply to respond. So our emphasis has been on getting providers to know about it, to understand it, and then training them to do it and funding them to open PrEP clinics. So we have launched in 7 counties in the health departments, and we have 3 additional counties that are putting their applications together. Our Medicaid program, we worked with them 2 summers ago to make sure that they would cover PrEP so we didn't have a new health disparity related to PrEP. Next slide. So we want to continue expanding the number of jurisdictions. We're sort of roughly going down by incidence from most affected to lowest, but it's not perfect, and we still have some big counties where we need to get PrEP up and running. So then we're going to move into increasing consumer awareness and demand for PrEP, both through education done through those local health department clinics and outreach from them, as well as social marketing up at our level. We're establishing a prevention case management program to identify and do referrals for other needs that high-risk negatives have. It sounds like we're thinking the same as Washington State. And then, of course, evaluate implementation at Medicaid MCOs to make sure that it's really consistent, and offer training to those MCOs in having sexual health conversations because it's somewhat new. Next slide. Yeah, so the ACA drama is always irritating and challenging. So far, okay. Truvada is in all the formularies sold in the plans on our exchange, but we are down to just 2 carriers, CareFirst and Kaiser. And the loss of the CSR payments does mean that those silver plan costs, the prices are going up. And then there's the sort of much deeper, broader, longer-term issue of earned historical mistrust among persons of color that sort of leads to the suspicion of, well, what is this, and what is the government trying to do to us this week? Next slide. So we'd love to establish data sharing agreements with us in Medicaid so that we can at least have a fuller understanding of what's happening with PrEP through a publicly funded system, like how many people are being educated about it, offered it, prescribed it, retained, and we're making it to adherence. That's all I sent.
Hi, this is Katie. Can everyone hear me?
Yep. Yes, Katie.
Okay. Go ahead, next slide. So Michigan has a current PrEP program that's focused, like many of the other states, on awareness and building provider capacity. We have PrEP funding through the CDC 1506 grant, which focuses in Southeast Michigan. We have a significant media presence there in a variety of media and social media venues, and it's called Love Free from HIV. We have a website that has clinical guidelines, a PrEP provider directory, sort of PrEP readiness assessment tools and things like that. We have funded a nurse practitioner in the last year or two to provide consults to physicians who, mostly primary care physicians who want to prescribe PrEP but need a consult on how to do that. We are working on increasing capacity for referrals and perhaps prescribing in STD clinics and DIS trainings. We have a pretty robust CAB, that our Community Advisory Board, that inputs all of our activities. And we're working, like many of the other states, on how to measure PrEP when we have little bits of PrEP referrals and PrEP prescriptions and adherence all over in many different databases. Next slide. So our main goal in 2016 was to increase the awareness of PrEP through media in Southeast Michigan specifically. Our intents were to increase provider capacity and increase DIS and STD staff knowledge of PrEP and how to do PrEP referrals, and increase resources available to the public. And we did that through a wide variety of surveys and SEBA trainings and staff hiring and things like that. Our objectives in 2017 are to continue everything in 2016 and expand the media to high morbidity areas in the rest of the state. We will be funding PrEP navigators who will help with the financial aspect of it and also the adherence support needed in 2018. Michigan has looked pretty intently at doing a Data to PrEP program where, with our partners from the Detroit Health Department, where our concept is that we would mine STD data for people who look like they are at high risk for for HIV acquisition, either through rectal gonorrhea or rectal syphilis or more than one STD in a time period, and do a direct facilitated referral to PrEP. So we're working on that. We're trying to work on a PrEP surveillance system or common data definitions or common things that we add together to kind of give us a data-driven picture of PrEP in Michigan. We're doing this PrEP Policy Academy with Medicaid, and we are hiring a public health detailer, which we're trying to hire right now, which is a nurse who is going to work for our PrEP program and educate the primary care community through short pharmacy drug rep type education models to private provider offices. Next slide. Our challenges, and Dr. Human is on the call, and she herself is a PrEP provider who works with Medicaid daily, so she can feel free to say anything that I'm missing here, but adherence support is hard for us, navigating copays and insurance. Integrated service delivery, where a person can get PrEP from the same clinic that they possibly had their HIV negative test at, or a partner services interview at, or an STD test at. Right now we have, you can't really frequently get PrEP on the same day or in the same location that you were. We are having problems, of course, with capacity, just like everyone else mentioned, and like Marilyn mentioned, the concept of stigma and bias and health literacy and government distrust. Both in rural and urban areas, we see it manifest in different ways, but those are things that we have challenges right now. So our milestones that we hope to get out of this academy, we have actually already had a data sharing agreement with Medicaid, and we have actually already pulled Medicaid data a couple years ago on Truvada prescriptions. So we kind of have that in place, along with how they're pulling the data to estimate that for us based on an ICD-10 algorithm that we developed. So our policy work is more centered on helping people on Medicaid navigate copays for PrEP, looking at a medication therapy management at point of sale model that Medicaid has that allows the pharmacy to have a role in patient education and adherence support, which is billable. Our Medicaid program is pretty honest in that they are not as literate on PrEP as they should be, and so we have a co-education of staff plan, and billing barriers when it comes to multiple STD tests or RN facilitated deliveries of care of PrEP. And I think that's all I had.
Thank you so much. Now I apologize again for all of the technical difficulties that have kind of left us without time for some really good, juicy questions. But NASHP folks are going to follow up with individual states after the call to talk more about questions that you might have and connect you with subject matter experts, and also provide resources that NASHP and Health HIV have in order to address those questions. So again, I just want to say thank you so much for joining today's webinar. We hope that you complete the evaluation that's provided in the SurveyMonkey link. And also, we wanted to get from you dates that would be available in the next couple of months to hold our next webinars for the PrEP Policy Learning Series. So please make sure to check your emails. There is another SurveyMonkey link that was sent to you. So on behalf of NASHP and Health HIV, thank you so much to Dr. Smith and Elizabeth Perry-Krutzinger and all of you that participated today. Thank you and have a great afternoon.
Bye-bye. Thank you.